Good morning, everyone. We'll be talking now about a proximal tibia deformity, which was corrected acutely. So this is a 27-year-old radiologist presents with pain in the knee since about 3 years. He's finding it difficult to stand, work, especially doing ultrasounds and all. So he wanted some correction happening for that tibia deformity. The cause for the deformity was probably a growth arrest, or there was some growth there, which is like an exostosis, but this was not like a hereditary exostosis. And he had this virus. Looks like proximal tibia procurvatum as well, but hardly any flexion deformity. The malalignment test showed that the femur was pretty all right, just that LDFA was 84, which is just a degree above 85. So MPTA here was the main culprit. And the sagittal views showed the PDFA was normal and PPTA was around 71, but there was no flexion deformity. So the question was whether we want any correction happening in the sagittal view as well. So the other issue was, again, he needed to resume work, didn't have any leaves left. So we wanted to fix it with internal fixation. And then the question of healing, whether an open wedge osteotomy or a closed wedge osteotomy. So we also did that planning on the trauma CAD. This is showing that open wedge correction, proximal mechanical axis with the MPT as 87 and the distal mechanical axis. And the right image shows the planning for the nail. We did the tab plan 3D planning from those X-rays. This plan was made more for a neutral wedge, correcting both the deformities, getting into the oblique plane, found out what plane it is and how much wedge on the neutral wedge we would need to excise. This is showing the correction on the 3D, closing on the lateral and lateral cortex, small opening on the medial, and plan for the fixator. We could also plan for the nail here in the tab plan 3D. So here, what was more important was how we executed this. So we did the marking for the deformity. The joint line was marked with the K-wire under C-arm. One can see it here on the skin. And then with using a goniometer, marked an 87 line. This was also passing through the proximal femoral axis, which was the same, and a distal axis, anatomic axis, and a marking of the cora and osteotomy was done. So we used polar wires here. So this is the proximal polar wires, passed perpendicular in both planes. And these are the distal wires showing the white arrows showing the perpendicular two wires. Then we passed shank screws over these wires. The shank screws we were wanting to use as polar screws, also as a sort of standby if we need to use a fixator to hold the correction while we pass the nail, we even pass the nail. So showing the perpendicular shank screws there on the left image. Then we mark the cora and the ACA. So here we planned for the neutral wedge with the hinge just inside that concave cortex. And drilled for the osteotomy. That's showing the wedge there. And then the nail entry was made. This is the left image is showing a post-op image of the slightly bigger incision than the normal incision we make. Then through the drill bits, that's the osteotome which is going for that wedge, neutral wedge correction, directed distally and then proximally as well. This is a bone spike just to prevent that soft tissue damage. And then just that lateral cortex was removed. Nothing, no big wedges taken out, just that lateral cortex was removed, and rest of it was just closed with the force to compress the portion. Then the guide wire was advanced. Here now in the sagittal view, we were encountering issues when we were passing the nail, that it was hitting the posterior cortex initially. So we added more polar wires there. The orange arrows are showing the polar wires. But then when the nail was crossing the osteotomy, it was tending to pass. That red arrow on the left image is showing it's not central in the canal. The culprit there was this bone spike, which was not letting the translation to happen. So we added one more polar wire in the distal fragment to block that canal anteriorly, so that the nail goes more central in the distal fragment. And from then on, then everything went on smoothly. The polar wires guiding it through the center, and the white arrow there is pointing to the hand which is holding the distal shank screw as a lever to hold the correction in the frontal plane. So at the end of, once the nail had passed through the osteotomy, we had parallel aligned pins on both sagittal and frontal planes. And then the shank screws were removed and the nail was locked. With the cookie cutter, we got some cancellous bone, which was then inserted at the osteotomy. And these are the post-op X-rays showing the alignment as planned. The HKA there is 182, which is probably from the distal femur. The MPTA here is 88. So at 6 weeks, because this was done pretty minimally invasive, this was closed, lateral cortex is already healed, and the medial is healing as well with the cancellous graft. He had resumed his duties he was still on a pair of axillary crutches, elbow crutches, but he had resumed his duties. This is at 2 years follow-up with good healing and normal function and a happy patient. The learning points here are one needs to plan these acute corrections well and execute them also well. So one would encounter issues, especially with the proximal tibial osteotomies, to hold the fragment well. So the polar wires act as blocks. They control the direction where our reamer and nail is directed, and it also reduces the canal size, especially like in the distal fragment, where one would expect that it will follow the center of the canal. There the polar wire was blocking it and directing it well. One can use the fixator to hold the correction, but more importantly, it will help in the rotational control as well. And in proximal tibia, where we are locking, more than the transverse mediolateral locking, the oblique locking is going to help you to control, hold the fixation well. Thank you so much.